Dr. Mattke, I'm so pleased could join us today. He is Research Professor of Economics at USC and the Director of the Center for Improving Chronic Illness Care. He's an expert in innovations to prevent, diagnose, and manage chronic disease. He's going to talk about early detection of cognitive impairment in primary care, finding the best tool to use. I'm hoping you're going to solve my lifelong quest for the best tool.
Thank you, Freddie. I'm afraid that's not going to happen. I'm trying. So, why am I concerned about early detection of in primary care? About 2/3 of dementia cases are reportedly not ever diagnosed. So people have it, people know it, sort of, the family knows it, but they're not really diagnosed. And that does matter because with a diagnosis usually comes support, access to healthcare services, social care services, and so on. What's even more troubling, if dementia is diagnosed, that is typically at moderate or severe stage. So pretty late in the disease process when many interventions that we do have do not really work anymore. And anecdotally, primary care physicians rarely ask proactively about cognitive impairment. So if somebody really brings it up, if the family pushes for it, if they say we are really, really worried, then this might get investigated. But it really relatively rarely happens that a primary care physician would proactively ask, just like they ask about your exercise, your diet, they would not really ask proactively about your brain health. And we're currently doing a study in Medicare data, and we see that only about 7% of the expected number of cases with mild cognitive impairment are actually diagnosed these days, which is a really, really low number. And it's surprising because this is a very prevalent condition. About 20%, close to 20% of individuals in Medicare 65 and up have mild cognitive impairment. Not necessarily a severe stage of cognitive impairment, but still it's a diagnosis and we need to make it, and apparently we don't. So why? Why on earth is the diagnosis rate so low? There are lots of root causes, and many people have talked today about it. Stigma, denial, we can't really do anything about it attitude, and then the crowding out of brain health with more pressing problems like diabetes, heart failure, and all of these things. And there's also the US Preventive Services Task Force has a so-called I rating on cognitive screening. An I rating does not mean that they say it's useless. They say we do not have enough evidence to conclude whether it is beneficial or harmful to screen elderly adults for cognitive impairment. The advantage of a positive rating would be that this becomes automatically a covered benefit under Obamacare plans and usually under most other health plans too. So that would mean that universal screening would be covered, but as long as the evidence is lacking for the net clinical benefit, that's not going to happen. And then there's a very practical problem in that there is no dedicated reimbursement in the US for a brief cognitive assessment. So the CPT catalog that defines the medical services that can be billed to insurance doesn't really have like the MiniMental type brief cognitive assessment. And that's unusual. In many other countries, you can actually bill for such a test. In the US, strangely, you can only bill for the complex tests that our neuropsychologists do, but not for the brief cognitive assessment that is being done in primary care. And then there's the Medicare annual wellness visit. There was a great expectation that this preventive service, which is the first in Medicare in a long time, would help with picking up cognitive impairment, because there's a statement that a Medicare annual wellness visit must include an assessment of cognitive state. Unfortunately, the rule that defined the requirements of the wellness visit didn't really make explicit what that assessment means. Right? So you're not really concerned about your memory, aren't you? Is sufficient to make the cut, and you can document that, and then you have met the requirements, and you move on. So research has shown by my colleague Julie Sissimopoulos in USC that only in about a third of the visits somebody is actually asked about cognitive state proactively, like in a formalized manner rather than just sort of casually, let alone assessed systematically. So why is this a problem? One might say, well, early stage cognitive decline, these people are cognitively intact, they're functionally intact, they can live their own lives, not such a big problem if you don't pick it up. And that's actually could not be farther from the truth, right? There are a lot of reversible causes of cognitive impairment in the elderly, like vitamin B12 deficiency, thyroid malfunctions, badly controlled hypertension, badly controlled diabetes all interfere with brain function. There are medications that interfere with cognitive function, and you can change those. There's normal pressure hydrocephalus. There's all kinds of things that you can improve where you can actually reverse cognitive decline with simple medical intervention, but really only if you ask for it and know about it. Even if this is a irreversible course like Alzheimer's disease or worse, not knowing about these early stages deprive a family of the opportunity to plan, right? If you know that there is a potentially life-changing disease, you have to adjust, right? You can't just sort of ignore it and move on. So you have to think about financial planning, about living arrangements, about safety, about driving, and so on. And it's actually better to do that when there is still time and the affected individual is still reasonably functional, because then they can participate in these decisions rather than being committed to a nursing home because nobody knows what to do anymore. Lifestyle interventions have actually shown to slow down cognitive decline in early stages. There's the FINGERS study out of Finland that has shown that a multi-domain intervention, diet, exercise, cognitive stimulation, can actually reduce the progression. And these are things that we should do anyway because they're good for your heart, they're good for your brain, and if you can stave off cognitive impairment for a couple of years, somebody might just die peacefully of a heart attack while fully intact of their mental capabilities. Then there are symptomatic medications, right? They are not perfect, but they help with improving cognition, and at least they can give a person more ability to function. And we shouldn't ignore that, even though some feel that they are not really all that powerful. Most, but not least, of course, we are getting to disease modification in Alzheimer's disease. Many of you have followed the aducanumab story. It was a bit unfortunate that this ended up this way, but now we have lecanemab, which is a drug that is very similar to aducanumab, and they have just released, Eisai and Biogen, that this drug met its primary endpoint in 2 phase 3 trials and met almost all of the secondary endpoints, with details to be released later. So there's a drug that will reduce cognitive decline in early stage Alzheimer's disease, right? The indication is MCI or mild dementia due to Alzheimer's disease. If we don't look, we can't use that drug. And if you look too late, the patient is no longer in a treatable range. So this is a very important call to action for everybody to pay more attention to these early signs of cognitive impairment. So how can we change that? Attitudes and habits are really hard to change. Like, doctors don't want to ask, patients don't want to know about it. The general attitude, it's normal aging, we can't really do anything about it, so let's ignore it. That will change, but it will change slowly, and we need to change it fast in order, especially with these disease modification treatments on the horizon. The payment levels are unfortunately, and the panel hinted at that, unlikely to be commensurate with the effort that it takes. Right? So even if you pay for a brief cognitive assessment, these take 15 minutes, and 15 minutes is a lot of time in the day of a primary care doc. So in the short run, better tools can help, because if we make it easier for primary care docs, we can see that things are happening. Like depression, for example, was also a pretty much overlooked, ignored condition in primary care unless it got really, really bad. Today, it's pretty commonplace that you do a brief depression screening, PHQ-9, even prior to you seeing your primary care physician. And it's routinized, it's simple, and it can at least assess quickly your mood and see whether there's more follow-up required. So how can we apply such lessons to primary care physicians? There are actually two types of tools that we can use. They're triage tools, because dementia and especially Alzheimer's disease share many of the risk factors that we know from cardiovascular disease, right? Like chronic conditions like hypertension, heart failure, diabetes, hyperlipidemia. All these vascular risk factors are also risk factors for dementia. Of course, it's an aging-related disease. Women are more likely to progress. Minorities are more affected, probably because of their higher burden of chronic disease. So we can actually predict a person's risk of having cognitive decline before he or she walks into the office. Right? This is such a common disease in the elderly population that these prediction models actually work pretty well. It doesn't allow us to say this person has cognitive decline with any degree of certainty, but it does allow us to predict the risk that somebody has cognitive decline, and by that, a primary care doc can actually triage. He or she can say, well, with a 35% risk in that person, that's something where I should actually pay attention, as opposed to 65-year-old Medicare, perfectly healthy, nothing else. That, in that case, the risk is very low, and unless somebody brings it up, you can probably wait with it. And that's not new. I'm a cardiologist by training. I don't even know what's going on here up north of the aortic arch. But we stopped treating cholesterol and blood pressure a long time ago. We treat expected risk of cardiovascular events. There are the so-called AHA-ACC equations that tell us, based on biomarkers, age, sex, personal history, whether or not you have an elevated risk, and that is 7.5% or higher, of having a major cardiovascular event like stroke or MI in the next 10 years. That number gets treated, right? So even if your cholesterol is normal, you get statins. Even if your blood pressure is sort of roughly normal, you get vasodilators, and you probably should take an aspirin. So that approach has been extremely powerful in cardiovascular medicine and has been one of the very few things that actually very few medical interventions that reduce population-based mortality. And given the shared risk factor risk factors with dementia, these interventions also lead to declining incidence of dementia by age in high-income countries. Right? We always are fearful of the tsunami of dementia because of population aging, but if you look at the epidemiology, it's actually leveling off. It's much less dramatic than we thought, and the only reason for that is that we control these risk factors, and the current generation of elderlies grows into their 70s and 80s, having been fully exposed to statins, to ACE inhibitors, to aspirin prophylaxis, and really aggressive management of these risk factors. If you look at middle-income countries, that is nowhere nearly the case. We are doing a study in Brazil, we are doing one in China. Risk factor control is awful. Dementia incidence is exploding just because everybody comes to age with this risk unmanaged. But then there's also the brief cognitive assessment tool that then can be applied to these higher risk individuals. So there are established tools, you probably all know them, the MiniMental, the MoCA, but they do take about 10-15 minutes to administer and score, and they're not even all that sensitive when it comes to early stage cognitive impairment, and also not that specific. So they have a specificity of about 75%, which means you have 25% false positives, and that's a lot if you think of the large numbers of people above 65 whom you might see. So we clearly need to do better than that. And I'm currently sharing a work group on what should be the properties of a brief assessment tool that can be used in primary care. So here's what we came up with, and that is sort of under review, so we hope to publish this soon. 10 minutes or less to administer and score, ideally non-proctored, right? So something that the patient can do on their own in the waiting room, because everybody has to wait anyway, so you might as well do a brief cognitive assessment. 80% or better sensitivity and specificity for early stage cognitive impairment, right? Like many tests can detect severe dementia. Most physicians can actually see that. I mean, you just have to talk to the patient. It's not that hard. But these subtle changes are actually not that easy to pick up. So we must get to tests that make that work with adequate specificity and sensitivity. We need to have something that is available in multiple languages, obviously. We talked about this in this panel a lot. And neutral to educational background, right? Particularly the MiniMental is pretty sensitive to how much schooling and how much training you had. You have this interesting paradox that even in recently rich countries like South Korea or in middle-income countries like Brazil, you have very high rates of mild cognitive impairment measured in the elderly population, but you have roughly comparable rates in the elderly population relative to high-income countries. And the reason is that in these countries, large parts of the elderly population, in particular in rural areas, had next to no formal schooling. Right? Because these countries are just getting rich. They haven't really started in the 50s with 12-year education. Many can barely read and write. So they fail the MiniMental, not because they're cognitively impaired, but just because they cannot understand the test. So we need tests that are sensitive to the fact that people may be semi-literate, illiterate, may have to be in a different language. And in an ideal world, we would have to have digital tests because they are more scalable, they are easier to administer, but then there should be a paper alternative. It should be compatible with EHR entry because the way that this happens today is usually that the physician has to scan in the completed MiniMental into the medical record. And of course, nobody ever looks at scans. People only look at coded fields. So you need a test that integrates into the record and has coded fields that we can actually search for. And then, of course, we need to test and validate these instruments in diverse populations. It really doesn't help if we develop them on 50 college students and then think it's great. So this is harder than it sounds, right? There's a lot of tests. I mean, if some of you were at AAIC this summer in San Diego, half of the booths were some digital or some testing company for cognitive impairment, a lot of them. Some of them actually perform reasonably well, at least in their initial testing with early stage cognitive impairment. And they're often kind of the morphing of existing instruments into a digital format. Right? So they take things like the clock draw test and digitize it, the animal naming test and all these things, and make a digital version of it. But some are sort of completely new approaches to cognition and executive function and whatnot. So there's kind of a large variety of these things. The good ones are actually self-administered and score automatically and then generate a report, which is great because then it saves clinicians the time to go over the test. They have the result and they can discuss the result with a patient just like they discuss cholesterol levels. But these tests today were all designed to meet the Medicare requirements for what you can bill in terms of cognitive testing. So what you have to do is a multi-domain assessment to meet these requirements, and you have to actually document all of these domains in great detail so that it passes a Medicare audit. As a result, what these things print out is often like pages over pages of neurocognitive detail. And we are using such instruments currently in a global pilot, and in many countries like Canada, Brazil, the primary care docs tell us, well, this is all nice, but what do I tell a patient if I have here 6 domains of cognitive function and brain health? What do I tell the patient? Can you give me just like a red, yellow, green score that I know roughly where somebody stands? But then, of course, the test isn't qualified to meet the Medicare billing requirements. They're also very popular with clinical trials because clinical trials need to test a lot of people and need to do that quite frequently. So none of the current users are actually the primary care docs, and thus these tests haven't been designed and optimized for primary care docs. And then, of course, they're often pretty expensive, right? They're meant for high volume use, so you have to buy a license or relatively high per use rates. And then again, if this is not reimbursed for primary practices, how should they manage like a $3,000 license fee? So, unfortunately, also the cheap options are diminishing. Like MiniMental and MoCA used to be free. They are now copyrighted, and the MiniMental you have to buy authorized copies, even though I heard most docs just copy them and just do it anyway. The MoCA has become licensed and copyrighted. You don't have to buy it, but you have to undertake training, and that is, you have to pay for the training. There's the slums and ticks, they remain free for the time being, but you can see that more and more the free options disappear that primary care can use. And all of these options are paper-based and proctored, so they're relatively time-consuming. So, where does this leave us? Sadly, I don't have Freddie's answer. It's not likely that any of these automated tests will ever be free of charge, right? Because the development and maintenance costs are actually not low, but at least we want to get them to a point that we have sort of simplified versions, low-cost versions that give an easy report that primary care docs can understand, for which you don't need a PhD in neuropsychology to read. Just tell somebody, this is a patient about whom you need to be concerned, and then that's about it. One bright spot is that Eisai, one of the companies that does develop Alzheimer's drugs, bought the commercial rights to Cognigram, which is one of these digital tests. And I really like personally Cognigram because it's a very simple card game test, and so it's language independent, it's education independent, and it's actually to some degree fun to do. So this could be, if freely available, a pretty decent tool in primary care offices to give people something to do while they're waiting for their appointment. So the alternative is to develop a test with public funding, but it's always difficult to get public funding like NIH for tool development, in particular then if it comes to maintenance, because that's really something NIH doesn't do. And if it's a digital tool, you need to pay some sort of a maintenance fee. This means for now, the pen and paper versions will have to do. I still hope that we will get to low-cost digital tools, just because that is going to be a lot easier. And in particular, because the pen and paper versions are still pretty complicated and time-consuming, a triage tool would actually be great because it would reduce the volume of patients in whom you have to administer and score that test. Okay, so that's it. I'm happy to chat about individual tests if you have questions. I'm not sure how we're doing on time, but I thank for your attention.
Hi, I just had a question. You did touch a little bit on medications. I would like to know, is there any medications that you recommend for someone with dementia would be on? All I know is memantine, but that's all I know. Is there anything else better than that to help with dementia?
Memantine, Aricept is also. I mean, that's pretty much it. It's not
That's
really.
It. There's nothing much
there are
out there.
These two drugs that have some sort of cognitive effect on cognitive function. Not great, but at least some people benefit. Some people can't tolerate them because of the GI side effects, but every little bit helps, right?
Nothing over the counter. Like I've seen some neural stuff over the counter type of thing.
Those mostly help the manufacturer, but that's just me.
Okay. Okay, thank you.
Thank you.
Thank you. Yours.